Hey guys, welcome back to my channel. Today I'll discuss about Fogsi guidelines on management of abnormal uterine bleeding. Okay, so first initially they gave a summary of what is abnormal uterine bleeding and just points. Then again they detailedly explain each and every point. Okay, so first what is abnormal uterine bleeding? If there is any abnormality in the frequency, regularity, duration of the flow, and volume of the flow. If there is any disturbance in these 4 points, then it is known as abnormal uterine bleeding. In the classified the palm coin classification. And what are the different laboratory tests required when evaluating the case of abnormal uterine bleeding is we'll do CBC, urine pregnancy test, and they'll see some criteria for coagulation. It's a positive screening test. There is a screening criteria which I'll tell later. If you find that she comes under the screening criteria, then you'll do DT, platelet count, prothrombin time, and APTT. Okay, and TSH is done. Thyroid stimulating hormone test is done in every patient. Then, if the coagulopathies are positive, then you'll consult an hematologist and you'll do other tests like von Willebrand disease, dystosin cofactor activity, factor 8 activity, and von Willebrand factor antigen. Okay, these are all later tests. Okay, so what is the imaging studies? You'll do ultrasound. You can add a Doppler for suspecting AV malformation, malignancy, fibroids, and adenomas differentiation. 3D ultrasound can also be recommended. What are the different medications used? You'll do OC pills, oral progestins, tranexamic acid, and you'll see the dosage of progestins mainly. Like medroxy is 20 milligram, you'll give 3 times daily, and combined oral pills 30 micrograms of ethanol estradiol, 2 pills every 12 hours for 5 days, then 1 tablet for 15 days, and you'll control the acute episode. Okay. Um, tranexamic acid is given IV dose of 10 milligram per kg body weight every 8 hours. Then coming to AB polyp, so palm coin I'm telling. So first is P, that is palm, that is polyp. For this you'll remove the polyp and you'll give LNG-IUS. For adenomyosis, you can go for a treatment like NSAIDs, progestins, ocipils, LNG-IUS, even GnRH agonists. And for those desiring the fertility, so we should not give and not planning conception. Then you can go for LNG-IUS. After symptoms are reduced, then they can plan for pregnancy. So what are different managing of L? Okay, L is fibroid. So depends upon the symptoms. Same, mostly the adenomyosis symptoms can be seen. And grade 0 and 1 with 4 centimeter or less than 4 centimeter, you can go for hysteroscopic resection. In the woman of 40 years of age and no desires of fertility, then you can go for hysterectomy. Then M is malignancy with atypical hyperplasia. Surveillance is important. Actually, atypical hyperplasia, generally we should go for hysterectomy. Okay, if the woman wants medical management, then they can go for LNGIS or oral progestogens or LNGIS or oral progestogens, and there will be endometrial biopsy surveillance for every 3 monthly. Okay, and if there is malignancy like endometrial hyperplasia without atypia, then converting into cancer is only less than 5% over of 20 years of span. So we need to go for surveillance and early follow-ups. Okay. What is the surveillance without ATP? How we'll do is we can give oral progestogens or LNGIS and 6 month three. Every 6 months you should go for endometrial biopsy and two negative biopsy. Like this month and next 6 months, if there's two negative biopsies, then you can obtain her for discharge. That's about M. Another thing is if there is endometrial hyperplasia without atypia, then follow-up is required. Uh, Okay, like who requires a hysterectomy? Like if there is no follow-up, then you'll do hysterectomy. If after this 12 months also the endometrial biopsy is showing no histological regression, then you'll go for a hysterectomy. Uh, After giving the progesterone therapies, if there is hyperplasia getting reversed, like now there is hyperplasia without atypia, then the two biopsies are negative. You gave progesterone therapy. After the completion of therapy, again you did an endometrial biopsy, and again you have a relapse of endometrial hyperplasia. Then you go for hysterectomy, and there is persistent bleeding symptoms. Okay. Mm, and if the woman says no for the surveillance and medical treatment, then you'll go for hysterectomy. Sees any coagulation disorders. So von Willebrand disease generally will give a specific factor replacement or desmopressin. O is for ovarian, you can go for COC pills for 6 to 12 months. E is for endometrial, um, then the thing is you can go for tranexamic acid or mefenamic acid. Okay. So adolescents also you have specific treatment options we'll be discussing later. And next is introduction. So once again, I'll repeat this thing. So what are the different things? Like four conditions where there is abnormality. The reason is abnormal uterine bleeding. That is frequency, regularity, duration, and volume. PAM coin is an acronym for polyp, adenomyoma, leiomyoma, malignancy, coagulopathy, ovulation disorders, ovulatory disorders, endometrial, iatrogenic, and other not otherwise classified. Okay, so you'll do all this CBC and urine pregnancy test and you'll see the criteria for coagulation disorders. Then you'll do BT, PT, APTT, and all. Medications you'll go for COC pills, oral progesterone, stomach acid. Dosage is as follows. Then the first is polyp. Polyp you'll go for removal and NNGIS insertion. For adenomyosis you go for NSIDs, oral contraceptive pills. Dinosaurs and LHIUS. If it doesn't want fertility, if it want to preserve fertility and doesn't want to conceive immediately, then LHIUS is the best effective option. For leiomyomas, you for grade 0 to 1 and less than 4 centimeter, you go for hysteroscopic removal. For more than 40 years, who are not desiring of fertility, they remove hysterectomy. Then malignancy, if there is hyperplasia, and want medical management, the LNGIS and the 3 monthly endometrial biopsy. Without atypia, then you can go for an LNGIS or oral progestogens, and 6 monthly biopsy should be done. Um, Hysterectomy should be advised to the patient who is not following up, or the recurring of symptoms, or biopsy reports showing same thing, or after biopsy reports and progestogens, if the endometrial hyperplasia is returning again, then you'll go for hysterectomy. Okay. For AUB ho, you'll go for combined oral pills, and also AUB is also present. Okay. Now coming to introduction. So introduction is something like you have both irregular and heavy menstrual bleeding is known as AUB. So the frequency. So I told the four things. Na? So frequency is something like so normal is what is the frequency of days? What is the normal? Like you got a date today, and within how many days if you get next date, then date of periods, then it is known as normal. So within 24 to 38. Okay, within 24 to 38. So we all know. Generally, we'll say the 28 days cycle, right? So 28-day cycle. So you make the 28 into 38, and you already know 28. So 28, that 8 is converted to 4. Okay, that is it. So less than 24 is frequent, and more than 38 it is infrequent. Okay, next is regularity. Okay, if it is regular, like variations are 2 to 20 days, then it is regular. Um, Variations greater than 20 days, then it is irregular. Okay, if coming to duration of flow, like if it is flowing for 4.5 to 8 days, it is normal. Okay, so 4.5 days, if she's bleeding, it is normal. If it is more than 8, it's long. If it is less than 4.5, it is shortened. Volume, if 5 to 80 ml is normal, all the 4 days. Okay, if it is more than 80 ml, it is heavy, and less than 5, it is light. Okay, I'll again explain you this normal limits. So every time, whenever you get a abnormal uterine bleeding question, we will write these clinical dimensions of menstruation and menstrual cycle. It is according to FIGO. Okay, so first is frequency. Normal is 24 to 38. So frequent, infrequent, you write. Regularity, if it is plus or minus 2 to 20 days. Then duration of flow. 4.5 to 8 is a normal duration of flow. 4.5 to 8 days is normal, and volume is 5 to 8 is normal. Coming to etiology, which I already discussed. Okay, so P is polyp, A is adenomyosis, leiomyomas, you have that FIGO classification. So for easy remembrance, remember this. So you draw a uterus, and this is the endometrial cavity. Okay, if it is inside submucosal, there is no impact to the endometrial cavity, that is 0. Okay, coming to intramural, always start with less. Always start with less. Okay, always start with less than. So One is less than 50% intramural. So from one onwards, you know it is intramural, right? So one is less than 50%, two is more than or equal to 50%. Three is but they are totally extra cavitary, they're 100% intramural. Four is intramural, that is entirely within the myometrium. Okay, five is subserosal and again less than 50% intramural. Okay, 5 is less than 50% intramural, 6 is more than 50% intramural, then subserosal attached to the stalk is 7, and if it is not involve the myometrium, including cervical lesions, round ligament, broad ligament without direct attachment to the uterus and parasitic lesion, then it is 8. Okay, so 5 is less than 50% intramural, 6 is more than 50% intramural. Remember that. And this malignancies, you all know that coagulation, coagulopathy, ovulatory disorders. Then you have non-structural causes like endometrial, iatrogenic, and not yet classified. This is also. So, what is the history you'll ask about it? Okay. Um. So, you it is recommended to apply the history and conduct physical examination. And in women with AUB, and yeah, I told you we'll ask a screening test for coagulopathy, screening, not test, screening. Terms we'll use. Okay. First thing they should have heavy menstrual bleeding since menarche, since menarche. Okay. Second point, that is one point. Second point is any of the three. Like if she's having PPH, if she's having any surgery after that, there is bleeding. If this having any dental work after that, she's having bleeding. So any one of these three, see in this life she might have gone this dental work at least. So any one she is having one positive. Then bruising per month, she need to get like epistaxis per month or frequent gum bleeding per month. Then it is this thing and family history of bleeding symptoms should be present. At least two, like bruising and family history should be present. Okay, then it is known as so a heavy bleeding and history of PPH and family history is there. Then it is positive. Okay, if you see this. This table is very important. See, heavy menstrual bleeding, PPH, surgery bleeding, dental work bleeding, bruising 1 to 2 per minute, epistaxis 1 to 2 minutes, frequent gum bleeding, and frequent. See, if she is having bruising and frequent gum bleeding, okay, and she had a history of PPH and she's having heavy menstrual bleeding now, then she is a positive for coagulopathies. Then you'll do PTA, PTTI, and NBT, everything. Okay. Investigations, I already told you these things like CBC and bleeding and all, BTCT and all. And TSH is done in all patients. Imaging, they'll do transvaginal ultrasound is the best one, most acceptable one. And if you're suspecting any intracavity lesion, then saline infusion. Okay. So this is the palm coin, which I already told. P and mainly the leiomyomos ficus classification start with submucosal, then one is less than 1% intramural. Okay, start with that. And history, you'll do physical examination if required, and you'll go for this coagulopathy screening, that is heavy menstrual bleeding. Then you have one of the following with this PPH, surgery, bleeding, and dental work bleeding, and two or more, that is bruising, epistaxis, frequent gum bleeding, and family history. In laboratories, you'll do CBC and all, and imaging, you'll do transvaginal ultrasound, and saline infusion if you want any intracavitary lesions. Now coming to management. Management is very, very important. I'll tell you with the doses, just remember easily. So first thing is every time we know in abnormal uterine bleeding, we'll give oral progestins or multi-dose COC pills and tranexamic acid. This is grade 1, level 1 evidence. Okay. Oral progestins which I'm telling, the oral progestins which I'm telling, uh, generally they'll give these progestins. We'll remember we'll see in day-to-day in OPD days. No? So norethistron acetate is generally they'll prefer in India. So norethistron acetate will give 10 milligram 3 times a day, and this is the hormonal therapy preferred for acute heavy bleeding. Okay, if there is norethistron acetate is not there, pharmacists everyone is saying norethistron acetate is not available now. Then you can for medroxyprogesterone acetate. Even this has been used. Okay. Medroxyprogesterone acetate 20 milligram orally 3 times a day. So Why to norethistone is easy to remember. Norethistone will give 10 milligrams and medroxyzistone is acetate will give 20 milligrams. Okay. Acute episode generally, if a patient came with acute, like she's saying that, ma'am, I am bleeding since 2 days and these many pads I'm changing, see 6 to 7 pads, I'm totally soaked. I'm bleeding this much. First, you'll do CBC and urine pregnancy test and rule out pregnancy, followed by you need to start some medical treatment. Na? So you'll start COC pills, which are containing 30 micrograms of ethinyl estradiol, and this 30 micrograms of ethinyl estradiol with some progesterone added, we'll give 2 pills every 12 hourly for 5 days. Okay, then 1 tablet per day for 5 days. Understood? So first we'll give for 5 days 2 pills, morning night, morning night, morning night, morning night, morning night. After 5 days, and next 15 days she'll take 1 tablet per day. Okay, this is to control acute episode of bleeding. And see, oral contraceptives have a nauseating feeling, so you should give antiemetics for them. Okay, Nexivic acid can be given alone or combination with this COC pills. IV doses 10 milligram per kg body weight every 8 hourly. Okay, bleeding if it is controlled, she should give the oral dose. Desmopressin in 1 milligram doses. Okay, that's about this thing. Okay, polyps. Polyps, you can go for hysteroscopic removal. I already told adenomyosis, you can go for combined NSAIDs, progestins, COC pills. You can give general chaconis. Leiomyomas, surgical management, I already told. Then coming to endometrial hyperplasia, which I already told this thing. Okay, surveillance. And for ATPI, you'll go for 3 months surveillance. For without ATPI, you'll go for minimum 6 months surveillance. Okay, then this is a flowchart. Yeah, remember this thing. So, if a woman came, in a perimenopausal woman, came with abnormal uterine bleeding, so you will ask history, since how many days you are bleeding, you'll do physical examination, you'll do any medications, you'll ask about any medications you took, PCOS, features, cervical vaginal pathology, you'll do that. Like you should see that if the cervix also, if there is any lesions, then also she'll bleed. Those things. And prolactin levels, you should test for pregnancy, the thyroid hormone and prolactin levels. Done. Now, if she's adolescent or age of less than 35 with a no risk of endometrial cancer, then you'll give oral contraceptive pills, that is 35 micrograms, which I already told. Or you can go for cyclical progesterones like medroxy 10 milligram per day for 10 to 14 days per month. Mm, Even giving this, there is heavy excess of bleeding. Then you'll do endometrial biopsy. If endometrial biopsy is normal, then you'll go directly you'll do endometrial biopsy in OPD. Okay, if endometrial biopsy is normal, then you'll go for ultrasound. Okay, if everything is normal, then you will go for hysteroscopy. Okay, these people think, these people according to them is uh, see cost. Okay, cost is the thing which you should keep in mind, because she came, she got tablets, again she came with bleeding. In the OPD only you'll do biopsy. You are the dealing doctor, right? Now, if you are after biopsy also he's not getting control, then you'll refer her to radiologist for ultrasound. Okay. If an ultrasound is also everything normal, then you'll go for invasive procedure like hysteroscopy. Okay, see this one. If adolescent or this thing with other risks of endometrial cancer, or if she's if more than 35 with suspected ovulation, then you go for endometrial suspected anovulation. Sorry, you should do endometrial biopsy. If it is normal, then same procedure. If it is hyperplasia without ATPI, then you can go for medroxyprogesterone acetate or daily megastrol 40 milligram, or you can insert Mirena. Then for them, this without ATPI, you should report biopsy 6 months generally, so 3 to 6 months they give, and refer to gynecologist if hyperplasia persists. Refer to gynecologist, they are saying now. Actually, this flowchart is general practitioners who follow. Okay. Then hyperplasia with ATPI is refer to gynecologist. Adenocarcinoma refer to gynecologist. Okay. This is the management. So, a woman who having high risk of relapse like BMI of more than 35, then these people should get 6 monthly endometrial biopsies recommended. Okay, so I'll just repeat this thing. yeah, this medical management. So you can go for oral progestins or multi-dose regimens of oral contraceptive pills. You can go for oral progestins, that is methoxyprogesterone 20 or norethistone 10, 3 times daily. Acute episodes will give ethanolistamol 30 micrograms, 2 pills 12 hourly for 5 days and 1 pill for 15 days. Okay, and tranexamic acid 10 milligram per kg body 8 hourly. Then, if she's adenomyosis, then you can go for NSAIDs and other COCPs, dinogens and generation agonists. Okay. If she's a premenopausal woman and you'll take history and all that, not only history, physical examination, you'll do a lot PCOS, cervical vaginal pathology, and you'll do tests, pregnancy test, the ASH and prolactin. If you'll give a hormonal pill, 35 and or as medroxyprogesterone. Okay, then if the bleeding control, then you'll go for endometrial biopsy. If the biopsy is normal, then you go for transvaginal ultrasound. If ultrasound has shown no pathology, then you go for hysteroscopy. Okay, if she's high risk of endometrial cancer, then you do endometrial biopsy. If it's normal, then same procedure will be followed. If she's having suspect an anovulation, also you'll do endometrial biopsy. If endometrial biopsy shows without ATPI, you'll go for medroxyprogesterone or Mirena and biopsy 3 to 6 monthly. If hyperplasia with ATPI, refer to gynecologist. Adenocarcinoma, refer to gynecologist. Okay. Now, okay. Now coming to the ovulatory disturbances. So ovulatory disturbances is then oral progesterone is the first line of choice. You can go for I already told N or M. N or M. M is of 20, N is of 10. We can be used at 10, date 15 to 25 of the cycles for 3 cycles. Okay. For endometrial disease, you can go for tranexamic acid. For iatrogenic causes, you'll go for NSAIDs. Okay. Iatrogenic is generally after inserting of IUD, there is heavy menstrual bleeding in some. So for them, you'll go for NSAIDs. Okay. NSAIDs can reduce the breakthrough bleeding, and they can at least 5 to 7 days you can go for breakthrough bleeding disturbances. Okay. Next is palm coin. Adolescents, sorry, abnormal uterine bleeding in adolescents. In this, you can go for see, in adolescents, you should ask about bleeding disorders and clotting abnormalities. You should find out the reproductive tract pathologies, injuries, and drug usage. Okay, bleeding disorders is about 20 to 30% cases. There is bleeding disorders. Okay, you'll ask about sexual history without parents. You'll ask the sexual history to the adolescent girl. Detailed menstrual history should be taken. Family history of coagulopathy. Okay. And you'll examine on the examination, you'll examine the signs of pallor, hepatosplenomegaly, and any hirsutism, acanthosis, nigricans. Okay. Gynecological examination should not be done unnecessarily. If you're suspecting any pregnancy, then you can go for gynecological examination. Okay. Then minimal laboratory investigations are CBC and okay, this thing. Then coming to general management guidelines, this is already we already learned the same thing. I'll tell about, yeah, this one, medical management options. So, first thing is inpatient. If you're there, if you're taking a patient of acute bleeding, you're admitting her, then you can go for start the conjugate equine estrogen or 25 milligram IV. Okay, or else you can start IV and tranexamic acid 10 milligram per every kg body weight, or aminocaproic acid. Okay, aminocaproic acid is given 4 to 5 milligram IV loading, then 1 gram every maintenance dose. 4 to 5, then 1 gram every hourly. Okay. Outpatient, if you're doing, then you'll give medroxyprogesterone, that is 60 to 120 milligram you'll give 20 milligram for 7 days and maintenance for 21 days. So UC pills can be used, monophosic pills for TID for 7 days, then once daily for 21 days. Tranexamic acid is also given. Okay, and this pictorial scoring, like sanitary pads, 1, 2, 3, 4, 5, 6, 7 days you'll score. If it is lightly stained on day one, there is 1. If it is moderately stained on day 2, it is 5. In that way, you'll score. If it is heavily stained on day 5, it is 20. So all the scores is taken. Even the tampons are been stained. Like lightly stained, it is score 1. If it is heavily stained, it is score. Moderately stained, it is moderately stained. It is this thing. Moderately stained, it is sorry. Moderately stained, it is 5, and completely stained, it is 10. So tampons, it is 10, whereas a pad, sanitary napkin, it is 20. And clots, if you're having one small clot of one 5 cent coin, it's 1 point. 50 cent coin is 5 points, and episode of flooding is 5 points. Okay, yeah. Whatever I taught you, this is the thing. Like for heavy menstrual bleeding, you'll give this ethanol estradiol one. 50, generally we'll prefer 35. If it is not controlling, then we can give 50 micrograms in the estradiol pill. Okay, 6 hour intervals you start. Then one pill every 6 hourly for 2 days. Then 8 hourly for 2 days. Then 12 hourly for 2 days. Then one pill every day. This is given for at least 6 months. Okay. Then therapy is maintained of 30 to 35 ethanol estradiol, and treatment is continued to for 3 to 6 months. Okay. Medroxyprogesterone can also be injection can be given, that is 150 milligram intramuscularly, followed by medroxyprogesterone tablet 20 milligram TID, like 3 times a day for 9 doses. Mm, if hormone pills or hemostatic treatment fails in at least 1 to 2 days, see, 24 hours or 36 hours, then you'll go for examination and anesthesia and therapeutic usage is necessary. Okay, so this pills dosage is increased in management. Okay, that's it. Thank you.